Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Healthcare Unfiltered Express with Dr. Chris Booth. Chris, thank you for coming on the show. You've been on my other show, but you're now on the Express version.
Thanks, Chaddy. Wonderful to be back. And I guess it's the express version because we're talking about exercise, so we're going to be walking quickly and talking quickly too.
We could be jogging a little bit. I mean, who the heck knows?
Yeah.
Chris, I this is we're going to talk about the paper that got a lot of attention in the New England Journal of Medicine, plenary session, all of that good stuff. Give us the background. Why would you even study exercise? I mean, exercise is good for you. Do I need a trial for that?
Chaddy, it's a great question. It's actually one that we debated 20 years ago as well. So this study goes back to 2007. I was a research fellow, and I just finished my clinical training in Toronto at the Princess Margaret Hospital. I'd come to the Canadian Cancer Trials Group here at Queen's University, where I'm now faculty, as a research fellow. So I was a young GI medical oncologist and also a former varsity long distance runner. So it was a convergence of a few probably important factors. And there was interest at the time in the cooperative trials group about running an RCT of exercise to improve chemotherapy related fatigue. And I was sitting in an airport hotel room listening to some colleagues talk about that. And as they're having the discussion, a light bulb went off because a few months earlier, some very provocative observational data was published in JAMA and JCO, suggesting that post-diagnosis exercise was associated with reduced cancer recurrence rates. And in 2007, I was young and naive enough that in this kind of cooperative trials group meeting, I raised my hand and I said, exercise is probably going to work for fatigue. People are going to feel better. But is that going to change anything? Probably not. I said, I think we should aim higher. And there's this pretty, intriguing observational data to suggest that exercise might actually improve cancer survival. We should aim for that and let's go big because that would potentially change policy and practice. And I'm sure most of the people in the room who are far more senior and smarter than me probably, rolled their eyes and thought, what's this guy talking about? But at the time, I was taking a graduate course in epidemiology. The course was called Principles of the Randomized Trial, and there was no exam. There was just one course assignment. You had to write a phase 3 protocol. So I wrote a draft of the protocol, which eventually became the Canadian Cancer Trials Group CO21 Challenge Trial, and it took off from there. And very early on, I knew something about trials and cancer and exercise as a runner, but I partnered with my co-chair, Professor Carrie Cournier from the University of Alberta, who's a kinesiologist who has devoted 30 years as a behavior change scientist, learning how to motivate and change perceptions in people who have had cancer to change their lifestyle and exercise. So he brought kind of the behavioral framework, and together we started pitching this. And to answer your question, which was common, back 20 years ago, friends of mine at parties or over coffee would say, why are you going to spend 10 years, it ended up being longer than that. Why are you going to spend 10 years and millions of dollars studying if exercise is a good idea? We should just be doing it. And it was a very legitimate question. And we had two answers. The first was, well, people know that they should exercise, but many people don't. For a variety of reasons, it can be hard to make that commitment, induce the lifestyle change. And so the reality is if we test it and we show that it works, then you can go to policymakers in the health system and say, this is something that should be embedded in care, because just telling people to exercise doesn't really seem to be working. But if a behavior change intervention with a personal trainer, life coach actually works, then perhaps that gets embedded in models of care. So that's the kind of, story from 20 years ago.
Very interesting. You have not aged a bit, by the way. I mean, yeah. So, Chris, what did the challenge trial show? Briefly, how many patients and what were the results?
So this study enrolled 900 patients. It was a very typical adjuvant colon cancer population. To remind Chaddy, who's forgotten everything he knew about colon cancer, not much has changed, Chaddy. We still give 5-FU, so you'd still be very comfortable doing that. But stage 3 and high-risk stage 2 colon cancer patients, they'd had surgery and finished their adjuvant chemotherapy. They were then randomized to the control group, and these patients received an educational booklet encouraging them to eat well and exercise, or the intervention arm. In the intervention arm, patients received the same informational booklet, but also a funded personal trainer for 3 years. And this personal trainer, life coach, physical activity consultant worked with the patient with motivational coaching and exercise sessions every 2 weeks for the first year, and then monthly for year 2 and year 3. And the whole objective here, the primary endpoint of the study was disease-free survival, but the objective of this physical activity intervention was to allow patients to increase their exercise over the first 6 months and then maintain it for a period of 3 years. There was a target, and they had to increase their exercise by something called 10 MET hours per week. A MET is a unit of energy expenditure, and if you and I sit here over the next hour chatting, we will expend 1 MET. So there's all these exercise tables that tells you how much intensity of different activities gives you how many MET hours. So if you and I were to meet up after ASCO and go for a brisk walk for an hour, it has to be fast enough, Chatty, that if someone saw us, they thought we were late for an appointment or we robbed a bank. So you have to be huffing and puffing. It's not a leisurely stroll, but if you walk briskly for an hour, that's 4 MET hours. So people had to hit a 10 METs, and they could do that biking, walking, jogging, swimming. Most patients took on a walking program, and they could hit their target if they went for a walk between 45 and 60 minutes, 3 to 4 times per week. So it's certainly a commitment, but it's achievable. It's not running a marathon or training for a triathlon. So that was essentially the intervention, deliver these behavior change sessions, a 1 hour session every 2 weeks. It started with coaching, motivation, goal setting, and then a supervised exercise session every 2 weeks for a year, and then monthly check-ins for year 2 and year 3. The trial enrolled 889 patients from 6 different countries, but the majority came from Canada and Australia.
So, what did we show and how long did it take to enroll? In total, how many years?
So the study was open and rolling for 15 years. In the middle of that was COVID, and it took longer than we thought to enroll. COVID didn't help, but also essentially most of the patients came from Canada and Australia. Canada has the population of California, and Australia has the population of Texas. So essentially, it was like running a cooperative trials group in those 2 states. So I think in hindsight, if we'd been able to kind of open this more broadly across the US or throughout Europe, we would have been able to answer the question sooner. But in any case, it was open for 15 years. There was an interim analysis along the way, of course, because in some ways this trial was asking 2 questions. Question number 1 is if you give cancer survivors a personal trainer, will they increase their exercise? And question 2 is if they increase their exercise, do their outcomes improve? So the interim analysis showed that clearly the curves were separating when it came to exercise. And in fact, the final results showed that patients in the intervention arm increased their self-reported exercise. They had an improvement in objective measures of physiologic fitness with VO2 max and their walk test. And most significantly, the primary endpoint, disease-free survival, was very positive with a hazard ratio of 0.72 that was highly significant statistically and clinically meaningful. And overall survival was also improved with a statistically significant hazard ratio of 0.63.
Well, first, congratulations on your perseverance and having a trial and randomized, getting it accrued, publishing it. All of this requires a lot of perseverance. I'm pretty sure you've had a lot of bumps through there. So really kudos to you. How has been the feedback to you, the media, the public, and so on? What in the last couple of minutes, curious, what was the feedback, the response, I've heard a lot of people were questioning how can you really implement this in the real world pragmatically? What has been the response?
Yeah, so I think those are all great questions. Is now, it's 15 years of hard work, but now how do we translate this into practice and policy? And I think this is not going to be straightforward. It's interesting, Chatty, if this was a drug with improved overall survival in the adjuvant space and a hazard ratio of this magnitude, and let's say we call this drug exercisumab, and it cost $200,000 and it made people sick, it would already be in guidelines, it would be funded, and we would be using in the clinic today. The reality is that this intervention is actually in some ways going to be harder to implement. There's a bit of an implementation paradox there because what we need to do and the model we have in mind, and we've already had remarkable interest in health systems around the world, is that the health system needs to embed exercise specialists in the cancer system. So just like at the cancer center, we have dietitians, social workers, speech language pathologists. The vision that we've had, and there's already discussions happening in many health systems, is providing cancer centers with funding to have an exercise specialist so that when the patient completes their surgery and they see myself for their chemotherapy, at the end of their chemotherapy, I could refer that patient to the exercise specialist to begin this type of intervention. This is not going to be something that everyone will want to sign up for. We hope now with the tremendous attention and interest in this, patients clearly find this very powerful and it's empowering for them. It's achievable for many patients. And I think just like, bringing out a new form of cancer medicine or surgery, radiotherapy, the next few years will be really key to see how we can implement this from a policy and practice point of view. But there's certainly been tremendous interest in moving forward. Clearly, the risk-benefit ratio here for this intervention is unlike almost anything else we do in cancer medicine. I mean, the number needed to treat here for overall survival is 14. So for every 14 patients that go on the program, exercise will prevent one person from dying. But unlike our other interventions, the other 13 people are likely going to have some added benefits from exercise as well. We have a formal cost effectiveness analysis underway, but suffice it to say this is likely to be highly sustainable for health systems. The initial back of the envelope cost for exercisumab over 3 years is about $5,000. So I think there'll be lots of discussion about how we implement it, but I think we're at a point where, we owe this to our patients to try to move this forward just like we would for any other new cancer treatment.
Dr. Chris Booth on Healthcare Unfiltered Express, thank you so much for doing this, and thank you for sharing your thoughts with my listeners and viewers.
Thanks, Chadi, for having me on the show.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.